All right. Good morning. The prevalence of spina bifida in the United States is estimated to be about 1 in every 3,000 births, which is actually quite common compared to other congenital anomalies. And given that 75 to 85% of these children will survive into adulthood as care has improved, it's clear that the population of young adults with spina bifida is growing. And there's no better audience than our residents today to be listening to this, because you guys are the future, and maybe you will help us improve how we take care of these children. So transition means more than just a change from pediatric to adult providers. So pediatric care is usually very family focused, holistic management centered on the entire family, compared to adult care where the patient is expected to make choices on their own. And for many young people, transition will mean a gradual shift of care from being supervised by their parents to taking care of themselves, self-care management. And without proper planning, this period can result in a potential care gap and lead to suboptimal healthcare utilization, deterioration in health, and increased complications. Today, we're going to be covering the challenges that we face in our clinic when we try to transition these patients, and possible interventions for transition. What happens? We're going to explore what happens if patients don't transition and are potentially lost to follow-up. And then we're going to close with possible urologic problems in the aging patient with spina bifida. So, there was a survey that was given to 140 spina bifida clinics in the country, and 34 of them answered. And most of these 34 clinics were CDC-sponsored clinics. So these are pretty high-quality clinics. And we asked, them, sorry, hold on. Sorry. So before I get to that, sorry. So we are part of, we are a spina bifida care clinic partner, and that means we partner with the Spina Bifida Association to make sure that we are following guidelines and standards of care for patients with spina bifida. And we asked, as part of that, they invited us to participate in a survey that they had developed. And one of the survey questions really focuses on how well we prepare families for transition. So when we distributed this survey to our clinic, we had about 12 respondents who were 13 years or older, appropriate for transition. And on the survey, we asked that in the past 12 months, have any of your child's care team members given you information, talked to you about the process, or talked to you about the necessary steps to prepare your child for transitioning from child to adult care? And unfortunately, only 33% of them said that yes, that they had been given any of this information. When we look and see how others are doing, and this is where the Spina Bifida Association gave the survey to clinics across the country, and of these, most of the CDC-sponsored clinics answered. So the majority of them said that they do have a transition process, but there is no written protocol. So it's really unclear, you know, how they adhere to the process if there is no protocol. They overall rated themselves as average in terms of being able to fulfill patients' needs in transitioning, and they had most of them had no mechanism of follow-up on the transition process, meaning they had no way of following up to make sure that that child had successfully transitioned. The barriers that they cited were a lack of providers to transition to, and also a lack of time. This idea of a lack of time is really important, because if there's anything to learn from this talk, is that transition, it's a process and it takes a lot of time. And it's not uncommon to walk into the room and see an 18-year-old and realize that it's time to transition them. you haven't had any of those conversations. You have no idea who they're going to go see and how much of their care that they're actually performing. So, in contemporary developmental psychology, adulthood actually doesn't necessarily immediately follow adolescence. Instead, there is this idea of an emerging adulthood phase that encompasses 18 to 30 years old. And we don't really expect people until they're 25 to 30 years old to be really assuming adult roles. And that is in respect to marriage, parenting, and work decisions. And so, in general, transition really ought to be starting before the ages of 18 to 30. And as we will see, some clinics start as early as 14 years old. So at our clinic, in last year, we had about 90 patients, and 2/3 of the visits were for very young patients, but 1/3 of them were for teenagers and young adults. And so that means that 1/3 of our patients, or approximately 30 patients in our clinic right now, should be undergoing transition. This means that we should be talking to them urologic specific goals, making sure that there's a plan of how they're going to perform intermittent catheterization, irrigation, how they're going to perform their bowel regimen, making sure that they're taking their medications without a parent there to remind them all the time, making sure that they know how to get their supplies and make appointments. I don't know if any of you have ever had the pleasure of speaking with a DME company to order supplies. I had to do it once, and literally for like 30 seconds, we were just repeating the same things to each other because I couldn't understand what she was saying. You have to calculate how many supplies that you need, how much will they ship, and whether you're going to run out. So there's a lot to consider, and unfortunately, a lot of these children have deficits in executive functioning, and so if it's difficult for me, then I can't imagine how challenging it would be for a patient with chronic disease like spina bifida. This is a tool that is often used in transition. It is a tool that can evaluate readiness for transfer of care. And as you can see, it's just a questionnaire, and it covers domains about managing medications, keeping your appointments, tracking health issues, talking with providers, and managing daily activities. And the child is supposed to, the patient is supposed to fill out degrees of self-efficacy. So whether they don't know how to do this, and whether they know how to do it. And this is how, once you have them fill out the questionnaire, unfortunately, this is what is supposed to happen after that. And as you can see, it's really time intensive, but basically after you score their questionnaires, basically anything that scores less than, they don't feel completely comfortable and they're already doing those activities. So that would be a score of 4 or less. You're supposed to choose 2 or 3 of those activities or tasks. And then this diagram is saying that you're supposed to educate and motivate them to work on these goals. And then you should have some sort of follow-up plan on making sure that those goals are met. So this is an iterative process, and until they score 4 to 5 on all of those questions, then they will be ready to transition to adult care. I don't know how many of our patients would be able to transition if we gave them this survey or this questionnaire. This diagram is also helpful because it does give you tips on how you can bill for spending time. But the important thing to take away from this is just that this is a very time-intensive activity. This is an example of what we see when we go to Spina Bifida Clinic. Our coordinator actually prepares this huddle for us. And when I was thinking about who would be doing this TRAQ questionnaire, who could be, unfortunately, I'm not sure that our coordinator has the bandwidth to be able to do that, because before every clinic, she's already spending a lot of time doing a chart review, touching base with families. She's doing a tremendous amount of care coordination before the actual visit. So here you can see that, she's talked to the family. They have some concerns that they want to have addressed at the visits. Here you can see that she's updated this patient who had a fracture recently. And so anyways, the point of showing you this is that she does a tremendous amount of work before our visits. And Spina Bifida Clinic is held twice a month right now. Additionally, not only is her bandwidth possibly maxed out, but this is what the families go through when they come to Spina Bifida Clinic. It's essentially a 5-hour medical visit day. And as you can see, they also have some imaging and labs done sometimes when they come. So it's really hard to figure out where you're going to fit time and effort to focus on transition. And it's possibly something that may even have to be held on a different day. But the bottom line is also that, our coordinator, she's really only devoted, or she's only allocated 0.1 FTE to do all of this care coordination. So she's already doing a lot beyond what you would think would be possible. So you definitely need resources, time, people to dedicate towards transition. I just want to go back to the consensus of a lack of providers, because I'm sure this is something that we have felt here at UW as well. And I wanted to share with you something that a lecture that was given by Duncan Wilcox. He is a pediatric urologist at the University of Colorado. And University of Colorado is sort of like this emerging institution on really spearheading the efforts in transitional care. So you may wonder, why can't pediatric urologists just continue to take care of these patients? And the truth of it is, and this is sort of borrowing from his thoughts, is that, in a pediatric practice, most of our patients are very young. And I looked at my own data, and last year, over 80% of the patients I saw were 12 years or younger. And although we have experience treating adults in the beginning of training, I'm not sure this is enough experience to be able to do all the decision making and have updated knowledge on care for adults. And there are also uncommon issues in pediatric practice, such as issues with sexual and reproductive function, managing and working up screening for adult malignancies, and just logistically, like knowing who to refer to when you need to refer to another specialist. So these are all reasons why we need transitional urologists. And there are some places, Indiana, I think, is they have possibly a pathway to really hone in or to train a transitional urologist. But otherwise, there's really no formal training programs. And I'm not sure it's really reasonable to expect pediatric urologists to take on all of this. So in general, what is held as sort of like the highest standard of care is this idea of lifespan model of care clinics. And there's really only 2 clinics in the United States, Spina Bifida clinics in the United States, who will take care of, who are united in their care delivery in taking care of a Spina Bifida patient from pediatric age to adult. So this is the one of the programs is the Children's of Alabama, and basically they describe their practice as taking care of prenatal diagnosed Spina Bifida patients. So here you can see that they collaborate with the MFM department and genetics, and then they follow that patient through to the pediatric clinic, where you can see these are all the specialists that are potentially involved in that. And then they really focus on transitioning around age 14, and that's where they use the TRAQ the TRAQ questionnaire, and they really practice at that until they decide whether that patient is ready to transition. And they also describe in this paper, they describe making an individualized transition plan. That's an ITP. So it's in school, I think a lot of kids can have an individualized educational plan. That's an IEP. And so they sort of sell this idea of an ITP. And basically, that plan consists of 5 goals that they hope to really be able to achieve before they transition. And then you can see here that when they do finally transition, these people actually go to an adult clinic, but there is the it is attended by the Spina Bifida coordinator. So the Spina Bifida coordinator has a presence throughout all of this, and they think that that continuity of care is very important. The pediatric neurosurgeon also attends this clinic, and the purposes, again, for that is to provide a sense of familiarity and continuity of care for these patients. The other clinic that really describes their philosophy as providing care for the lifetime of these patients is the Gillette clinic in Minnesota. And this is a little bit of a different clinic. It really, I think the majority of the patients they see are, they have cerebral palsy, but they also see patients with spina bifida. And the Gillette clinic is also part of a spina bifida clinic partner with the Spina Bifida Association. So this clinic is a little different because I think it's all in one facility where they see these patients with disability, and it's because it's really anchored by rehab rehab specialists. The facility is really geared towards having all the proper equipment, like all of the beds and their lifts, and that you can go and get your wheelchair appropriately sized up and adjusted. So their focus is really on, I think, a little bit more of a holistic approach to really making sure that these patients have all their needs met. It's interesting. They also describe, so in this, they see adults in the clinic, but they also developed an adult inpatient ward and they also decided to treat patients in their ICU up to age 25. So it's a very organized approach to taking care of young people with disability. So of these 2 places, I saw some differences. So obviously the one in Children's Alabama is more surgical specialty driven, which I think we might be a little bit more familiar with. And then the other one is really rehab focused. And so there are just different nuances to those clinics. I think the physical structure of the clinics are different. So here in Alabama, they were off campus and versus keeping everything on the same campus. And then there were age differences in terms of what they consider to be transitioning. The similarities, however, that both of these papers sort of had buried in their descriptions was that really they found that in their transitional clinic, only half of the patients were patients who had actually been followed previously on the children's service. And so the other half is coming from people who are self-referring or just, from the community. And I thought that was interesting because you would expect that most of the people, all these clinics were grown because you expected to be able to follow most of these kids. But the fact is that only half of them will attend the clinic. The other similarity that both of these experiences shared was that there's this cross-pollination and communication is really important between peds and adult providers. And what happened in both situations was that the adult, they took information from adult patients and they applied that to their pediatric practice. So for example, in Alabama, they found that most of the adult patients, once they transitioned, they were still struggling with bowel continence. And so what they did, so the pediatrics side took that information And now they incorporate the goal of really working on bowel continence before they transition. And similarly, on the Gillette side, they found that, pediatric providers were reluctant to give these patients powered wheelchairs. And what happened was that there was like a loss of independence when that happened. And so this encouraged the pediatric providers to move towards powered mobility a little bit sooner than they would have. So it's interesting and that the adult experience is informing the pediatric practice. Another place that really talks a lot, that shares a lot in the literature is the Indiana experience. So here, what they did is that they actually developed a transition clinic located literally across the corridor from their Spina Bifida clinic. And when they defined successful transition as a follow-up visit within 24 months of discharge, they were shocked to find that only 40% of their patients transitioned successfully. And most of these would happen spread out in the first and second year, even though they were told to follow up within 1 year. Now, of these who were lost to follow-up, they spent a lot of time trying to reach them, and they were only able to contact 6 patients. And of these 6 patients, 2 had established with a community adult urologist, 4 were interested and remembered the transition clinic. And in total, a net of 2 patients, they were able to recoup these 2 patients to come to the transition clinic eventually. And one of them went to an academic urologist. So the take-home message here is that 60% of these patients were lost to follow-up. And that means that there are patients with augments and channels potentially out there who have no follow-up. So clearly, there are barriers that patients are facing that are preventing them from continuing their care, even though there may be clinics available and mechanisms for them to follow up. And why is this? It is said that the young adult is susceptible to interruption of care because there are just competing priorities during this time in their life. And I looked into a couple of interventions that have been described. So this is from a Cochrane review, and they chose randomized controlled trials or observational studies looking at interventions to improve care transition. And they basically only found 4 papers to include in their analysis. And one of these is a workshop that was developed for Spina Bifida. We're going to talk about that. One of them was a web-based approach. One of them was a one-on-one meeting with a nurse to discuss transition. And another one was like standardized phone calls. The limitations in all of these studies was a small sample size, a short follow-up of less than a year, and lack of disease-specific outcomes, meaning if you tested this intervention in patients with diabetes, there wasn't like a hemoglobin A1C to follow up and see how effective that transition was or that intervention was. Their conclusion was that transitional care programs led to little or no difference in health status, quality of life, or rates of transfer. And this is one of the interventions that was included, and it was geared towards patients with spina bifida. So I wanted to look at that a little bit more closely. So this was done by the program in Los Angeles, and it was a 2-day workshop, 5 hours on the first day and 4.5 hours on the second day. And they spent the first day developing goals, and then they tried to work towards better defining a plan for those goals. And these patients were then supposed to practice strategies on how to achieve those goals. And the interesting thing here is, if you look at their flow diagram, is that only 5 patients out of the 42 received the entire intervention. And only 5 patients had received even the first day, which is when they were defining these goals. And so this just, not surprisingly, when they include everybody in the analysis, their intervention had no effect. However, they did learn some lessons, which was that there was an awareness that developed of the lack of adherence to treatment and transition plan follow through. And the authors, they said that they thought that this level of effort really called into question the intervention's cost efficiency. Most of these patients were Spanish speaking, 90% of them actually. And unfortunately, they found that for these patients, their parents were really unable to support them. And this was also because they were afraid often to ask questions, even though they said that they understood, they were reluctant to share that they didn't understand. They also found that the tools available were very limited and not specific or sensitive enough to the condition. So that was a very low tech approach. This was more high tech approach that was described. So this was describing that patients could, who were recruited to the study, could log in to the web and go through some educational thing. But then they could sign up for a texting service. And this texting service was linked to being able to contact a physician directly if they were indicating certain symptoms. And so I thought this was interesting because we are in the age of, all these kids have cell phones. And, it's possible that maybe something like this would be more effective because it's automated, it doesn't require a human person, and it will plug people into to getting the care that they need when they need it. So I guess looking through all of this, my questions were, does successful transition lead to better health outcomes? And if we were, if we had a really great transition program, would we be able to increase value-based care? If you look at patients with type 1 diabetes, this is a study looking at privately insured young adults in California. Across the United States. This was a national study. And you can see here that from the ages of 16 to 24, basically as you increase in age, the likelihood of seeing your endocrinologist goes down. And your utility of the emergency room goes up with age. So this is suggesting that, young adults are just not really using our health system efficiently. However, if they were seeing their doctor regularly, would this actually lead to fewer hospitalizations? And this is a study that actually came out of our children's hospital. So the complex care program involves children who have more than one organ system affected, and they have very regular follow-ups. Complex care is extremely involved in all of their patients. And when they look to see whether, these kids had preventable hospitalizations, it's also called ambulatory care sensitive conditions. These are conditions where it's thought that if you have high quality outpatient care, that you can prevent hospitalization for these conditions. And urinary tract infection is one of them. Unfortunately, what they saw was that hospital admissions for complex care children still occurred despite having good outpatient care within 30 days or within 2 years. And their conclusion was that maybe medical complexity trumps the influence of ambulatory care on hospitalization risk, meaning, these people are they're so complicated and they have the risk of hospitalization is so high and it's quite unavoidable. And you can ask yourself, the last patient with spina bifida that you admitted to the hospital, did that patient follow up? And I could think of one who did have routine follow-up, and she still got sick and got admitted. Now, going back to the Indiana study, what they did something very interesting, which was that they followed up on the patients who were lost to follow-up, and they compared. So they now have a group who followed up and a group who didn't, and they looked to see whether the hospitalization rate was different, and in fact, it wasn't. They also looked to see whether emergency room visits were different. They did find that there was a higher percentage of emergency room visits amongst those who were lost to follow-up. However, when you look at the paper, those reasons for emergency room visits were not urology related. In fact, what you notice is that those who transitioned, those who stayed nearby the center and went to clinic, they were actually more likely to have problems. So you can see here that they underwent channel revision, had a bladder stone, they had issues with their channels. So it looks like, patients who have active problems, that they are more likely to follow up. So this is another study from Michigan, and they looked at those who did not transition and who stayed with pediatric services versus those who did successfully transition. And as you can see here, those who did not transition, they were the ones who were going to the clinic more often. They were also the ones to use the emergency room more often. So this is suggesting that, those who need care, they will find it. Now, unfortunately, we all know that that there are certain things that are silent, right? That can happen. And these things need monitoring. And this is especially true for patients who we have performed reconstruction in. And I'm going to end with this, sharing with you from Dr. Huseman, who is retired now, but he apparently didn't have a problem with patients who had follow-up. He has 25 plus years of experience in taking care of these patients. And I sort of wish this was something that I had known 10 years ago. So basically, he looked at his series of patients who had augmentation, and he was able to provide very good long follow-ups. He found that, bladder stones, those will occur in 50% approximately with 5 years of follow-up. And he was able to reduce his rate to less than 5% using high volume irrigation. That means more than 240 milliliters of irrigation to really get the mucus out. He found a 15% rate of renal stones, and these patients are at very high risk for renal stones due to all of their metabolic abnormalities that can happen after their augmentation. Vitamin B12 deficiency is something that's always mentioned, but it's very important because if you do have vitamin B12 deficiency, they found that oral replacement is only sometimes effective. And if you don't have, their recommendation is that if you don't see an increased back levels, then you really ought to be using IM injections of B12. So these rates are not zero. They're actually pretty substantial. There is, he observed a certain rate of small bowel obstruction. So oftentimes what can happen is that there could be an internal hernia, or there could be a volvulus of intestine around the pedicle of your augmentation. He observed rates of stomal stenosis in his young adults, and this was especially associated with those who had developed obesity. And he really cautions that, you're deciding to do these procedures in kids, but then they grow up and the rates of obesity are very high in spina bifida, and this causes problems with their channels, with stomal retraction or the angulation changes. These last three issues are described from a series of patients who are augmented, and this includes, patients with valves or exstrophy. And what he saw was, there was the bowel perforation was associated with those who had developed problems with substance abuse and non-compliance. And they actually had one patient die, which I thought was a little bit low because we definitely hear about these patients. And then really long follow-up. There is a pretty non-zero rate of neoplasia, so adenocarcinoma and urothelial carcinoma in these patients, and so they do have to be surveyed and monitored. And then finally, the most sobering fact is that a great deal can develop chronic renal failure despite, you know, you having built in this reservoir to achieve low pressures. And this renal failure develops as a result of noncompliance from catheterizing. And also, interestingly, obesity contributes to this as well, he thinks, because what happens is that as they get more obese, they are less likely to catheterize, and this leads to this feeds into their non-compliance, and then they have upper tract damage. So this is just to show you that there are things aside from the perforation, but there are things that can be happening silently, and that is why these patients really need lifetime care, and that's why it's important to focus on transition. So basically, things that I learned from this was that, you know, successful transition, it requires a lot of time from the healthcare system. It also requires time from the patients and their families. You need an incredible amount of resources. You need a dedicated coordinator to transition. You need a social worker to help with the insurance changes that happen. And a nutritionist would also be very helpful to counsel these patients on how to stay fit. You need training for the providers and the patients. You need some sort of mechanism to prevent loss to follow up. And this, as you saw, requires a lot of energy to make sure that doesn't happen. Which is why I think something high tech would be helpful in that. And finally, you really need to protect these reconstructions that have been done. So I am happy to answer any questions. Thank you for your attention.
I think your slides are really rich, at least for the people who go to fight for issues. I know a lot of residents have been taking notes. So I think what I believe would be a good message for you to take home from it with you as residents and also as providers on the other side of that. We need to maintain the productivity of the division from a financial aspect. We are able to operate on patients above the age of 18 and the AFCH. That's going to be a green light from the administration to say, yes, you can do it. But also to have a team such as Dr. McAkron, Dr. Grimes, and also the new recruit into the adult side to help us build this team is going to be important. And finally, that last slide is really what you need to remember. And I think what you need to remember is that we cannot do it alone. Social worker, in addition to a coordinator, as well as health psychologist, would be of utmost importance for the running the practice. A coordinator to be able to go on the ground and communicate between the adult side and the pediatric side is going to be important. And that's why I want to introduce Callie, who had been hired as a nurse practitioner in the Division of Pediatric Urology as a transitional urology nurse practitioner, who's going to really take care of that coordination, which I'm not sure had been done appropriately before or not. But we cannot compare what we are going to do here to what has been done in other places. The culture, as you know, when you go to another practice, the culture is usually what governs your practice. And that's why I really want to thank Ruthie, because she knows the culture very well at UW. And I think even though she was very kind and quiet and sliding in some of the challenges, I think we're all now recognizing those challenges. So with that, I want to open it to all of you to tell us how can we do it and how can we make sure that we're really providing the best care for our patients. Thank you again, Ruthie.
Go ahead.
Sure. Thanks for the excellent talk, as always. I guess, one challenge that we faced logistically is, I think, transitional urology is hard to draw a box around, right? It's very heterogeneous. And I mean, it's my opinion. I don't know if you would agree or not, but there are adult patients with pediatric urology history, right? Who like had something, they were seen as a kid, or they had a reimplant or something like that, right? And then there's people like, I think that like when you and I, when we say transitional urology, we all kind of know what we mean, right? But it's hard to draw a box around that. And so I think one logistical, issue is how do we bring the resources to bear on the patients who need all of that, right? Who need to be truly seen in like a MDC setting, and they and they need to see, they have complex stone disease, they need urology, and they need this and that, and how do we like kind of focus on that, and then also take good care of the people who need kind of more routine follow-up, and then and be able to tell the difference ahead of time, right? Because when you start trying to figure out like, okay, we're gonna have a transitional urology clinic, great, who's coming to the clinic, and then you end up, it's like, oh, this is a kid who had a reimplant 15 years ago and is doing fine, but they get billed as a you know what I mean? Like those kinds of things. So that's a question for you, or what are your thoughts about how would you build that, like kind of sandbox mode? What would you do?
Yeah, so I didn't mention, but recently we had a I don't know, like an educational day with families with spina bifida. It was organized by Dr. Iskandar. It was held on a Saturday. I think it was in December. I can't remember. But actually, the attendance was great. There are a lot of families out there in the community who, and then there was actually a panel of young adults, like in their 20s, who talked in the afternoon, and they all mentioned that they just don't know where to go. I think that I think those who are having active issues definitely need to be seen in a multidisciplinary, because they're having issues for a reason. And then there are those who are otherwise well who can maybe have a lesser acuity of care.
Yeah, or maybe like, yeah, lower acuity who need kind of like routine, like they need, surveillance of creatinine, ultrasound, that kind of thing, kind of more routinely, but they're doing fine. Or people maybe, I think the hard thing is patients who should just transition to an adult urologist, right? Like they don't need like the team. They just need to establish with someone who's going to follow them. And then it's like, who's the right person for that, That's one thing we faced when we looked at trying to figure out, how are we going to build those clinics and who's going to be in them and who are they going to see and when and how and for how long, that kind of thing gets difficult.
Absolutely not. So I actually didn't mention, and I don't know if Frank is here, if he's listening, but we recently had a patient who got pregnant with spina bifida, and she had actually had a miscarriage before that. And so there's this whole aspect of, sexual and reproductive health that I didn't really go into, but and that all of that happens on a different campus, right? So it's really, you have to rope in those people too to help manage these patients.
Well, and then they just call, often me, which is fine. For like, hey, we have a spina bifida patient with an OG who needs a C-section.
Yeah.
What are you doing? Don't care. Come help us, right? And so, which on the one hand is fine. On the other hand is, maybe not the best way to handle that, or have the on-call person just sort of show up and do it. Also not ideal, So, yeah, there's lots. I mean, it's like, and that's just one example. I mean, like there's tons of stuff like that where it's like, what is the right way to do this?
And I don't think anybody really knows. That was my point of sharing. Like, I think everybody, very few centers actually publish their outcomes. We don't really know what happens there, but I'm sure that they're just as confused and scared like we are.
Well, and you mentioned Indiana, like just talking to Josh, he's, like Josh Roth, same problem. He's like, I don't know, like it's difficult to actually do it in practice, right?
Go ahead, Kyle.
Dr. Sue, great talk. I think what really stuck out to me was the care coordination piece.
Absolutely.
The 0.1 FTE.
Mm-hmm.
I mean, that's a full-time job. I think could be a full-time job. So how, I think in having, I'm thinking back to like at the VA a little bit where we had nurse case managers, because a lot of our patients at the VA have issues with transportation, low socioeconomic status. So we have full-time nurse case managers that help patients, get to their appointments, and they come from hours away. So they want to have all their appointments on the same day. So there's some parallels there. How do you get past those barriers, right? I know that's the $1 million question, but 0.1 FTE just seems like an embarrassment to me.
Yeah, honestly, I don't know who makes those decisions. Obviously not me.
No, it's not me.
She's punted to the vice chair of the clinical affairs.
Yeah, Jacob does an amazing job. She does all of the stuff that that is really at the heart of spina bifida clinic, and unfortunately, she does a lot of it on full time, whatever that means. She's an orthopedic nurse, so she's in ortho clinic otherwise.
But is the administration just not? They don't see it as value based, or
I honestly don't know. I don't know who the right people are to talk to about that, but it's clearly it's something that I definitely realized in doing this, is that she only has 0.1 FTE to do all of this.
Yeah, I have to interject and say, she doesn't know, and she had been here for 9 years. I don't know, and I sit on the leadership, quote unquote, at the AFCH. And I can tell you that the relationship between admin, people and leadership at AFCH and our requests is like the Russian mariachi. You know, you go talk to somebody else, talk, and you need to talk to another person, and then you end up talking to about 10 people, but nobody will make any difference. That's because, unfortunately, we don't have yet a value added to the pediatric hospital. And I wish that this will be transcended up to the leadership here, because that's really what happens, is that people do it because they love to do it. Those two people are doing it because they love to do it. They are not paid to a lot of things that they do. But thank you for making me angry. But
I actually think there is an argument here for transition on a wider scale at the pediatric hospital. And I always say this because when I presented some of my care planning stuff, I had interest from pediatric cardiology, home. They all want in on some idea of how to transition patients from pediatric to adult practice. The Cancer Center has really done a great job of implementing nursing navigators to fill that role because they've had some care coordination experience. They know how to work with DME companies, social workers, and they understand the health system enough to provide some of that core coordination. So I think there's enough here. There's like enough there to make an argument if it's a pooled resource between multiple specialties. And then my hope is that the value will be clearly noticed by the institution as patient satisfaction, compliance, and safety improved, right? Which is why that model has succeeded in the Cancer Center.
I mean, these are all, and I think the thing is that it's really, you have to prove that all of this is worth it, right? And that's incredibly hard to do based on the studies that I looked at. Like the metrics, how do you measure value is really difficult. But absolutely, whatever all you said is absolutely true. Yeah, it's a widespread issue.
And sorry, that actually wasn't my question for you. My question was, who sets the goals? Because there's so many of us in these visits, and I don't know that we have like a core huddle where all the specialties identify what their top goal is for that patient.
Yeah. Honestly, I think, Jaka, she looks through everything that we write at the end of the day, and she assembles all of that and sends it to patients. But I don't know if there's any like actual, final say or everything like that. They're all different specialists, and we all have different things that we want to look at. So unfortunately, she does something that I'm not sure, and I never really see. And she hasn't done it for a while. I asked her for some stuff, but anyways, but I think it's her. It's the coordinator, and that's why those people who wrote those papers, those are the coordinators for those clinics. There were no MDs on the papers.
Thank you.
Dr. TRAQ.
Yeah. Enjoyed that, Ruthie. So I was at the JDRF fundraiser on Saturday night, and I'm just struck by how the similarities between sort of this population and that population. It's adolescents with disease challenges. And they've done a very good job of sort of generating a community that these kids can go to these camps and see each other. They talk about their problems. So I guess there's some possibility there would be the first thing, drawing those parallels. And that you wrote that slide about the type 1 diabetes. So maybe you could comment on that. And the second is, these areas that are more challenging are potentially bear the more fruit in the future. And certainly applaud you for taking this on.
Thank you. Yeah. So did you push fundraiser? What did you say? Was that the AFC?
Juvenile diabetes.
Oh, juvenile diabetes. Yeah. Yeah. They have. There's a lot of studies. Again, it comes down to, I think, in the end, you want to know if you're saving money, right? What is the metric that you measure to really say that that all of this is beneficial? But you're absolutely right. There's definitely a community out there, and I think that's actually quite unique to Madison, because I've done spina bifida clinics in Pittsburgh and Seattle, and here, the families, they know each other, they talk to each other. their kids grow up together. And but then something happens and they all disappear. So and those are the people that need to inform, what we're supposed to do. So definitely think tapping into that group is really important. Thank you.
There are,
That's a question.
yeah, go ahead, please.
But Dr. Borza has a question.
Dr. Borza?
Great talk. So, to kind of piggyback on a little bit about what you were talking about with growing the team that manages this transition, in the sense that, I've looked into doing this for cystectomy patients. It's sort of a very different problem, but it's a complex medical patient that often has a lot of medical needs for a certain period of time and require this sort of multifaceted approach to optimize their outcomes. But it turns out that at a health system level, that is actually negatively incentivized. All of these coordinators, the extra FTE from nurses to track the patients and make sure that they have the best outcome possible is actually counter because it loses money for the system. Whereas the readmission that they would get or the need for a procedure down the road actually generates a substantial amount of revenue. And so when you try to sell this value proposition, it turns out that the cost part of the value proposition it works heavily against you. And so there's no financial way to make this argument. Like what they get from a couple clinic visits will never offset what they get from the hospitalization or the surgery that a patient would need down the road. And so you try to play up that the quality part and patient care, but I've found that a very difficult road to navigate to date. So I wonder if you have thoughts on that concept.
Yeah, that's unfortunate. Hospitals need to make money. They do it by people being hospitalized. I don't know. It's definitely a conundrum. But somehow there must be something saved, right? But you're absolutely right. A lot of these transitional clinics, they came because they wanted patients and families to be satisfied. And how does that play out in terms of cost? I didn't look into that, but you make a very good point. Thank you for that.
Again, just for time purposes, I know that you have another meeting. I want to thank the department for allowing us again to come every 2 years to come and present to you. We gave you an update on what's happening in the Pediatric Urology Division over the last 2 months. Basic science research we're conducting, as well as the research that Jenica is spearheading. And now with the transitional urology, this is a new challenge that we have. And finally, as you know, we're trying to really build a fellowship program here. So it's nice to see all of you guys. And I leave it to Dr. Williams to decide if you want to go with more questions.
Thank you, Ruthie. I just had a comment and a question. Actually, before I get to the comment, I wanted to acknowledge that Dr. Sue was recently promoted from assistant to associate professor. That's a big deal. My comment is that, as highlighted here, this is a challenging patient population, not an easy process to navigate, but that, lectures like this or spending some time in a clinic like this can be potentially inspiring for residents and trainees who may be interested in pursuing this. My comment is I remember spending time in Casey Furlick's clinic when I was a resident and seeing spina bifida patients coming in their wheelchairs, walking in. So that whole spectrum of disease, just as Dr. Grimes highlighted, adds to the challenge of this. So my question is, when you were presenting, I did a quick look online to see what transitional urology fellowships are out there. And the answer is, as you all know, is very few. I saw one pop up from Northwestern with Steph Keel, Diana Bowers, Elizabeth Yerkes rather. So for a resident who may be inspired by your talk, spending time in all of your clinics, what would be the current pathway to pursue additional training in transitional urology? Finding that type of fellowship, a GERS fellowship, Well, what's the current pathway for someone who's interested in doing this?
I actually have no idea. Does anybody know?
Yeah, so in Utah, most recently, they actually graduated somebody who went back to Toronto as a reconstructive transition urologist. He did 1 year of pediatric urology and 1 year with adult urology. And in Northwestern, or at least at Lurie's, what the purpose is that somebody will have an appointment on the adult side. So they will have access to the operating room on the adult side to be able to really get exposed to the cases of congenitalism or spina bifida or what have you. This is why when I started talking about what we have as a luxury here is that we are able to operate at AFCH on older patients than 18. And that would allow us at one point, really, if we have reconstructive urologists who would be interested in having fellowship, that we can work together to build a pathway. So the answer she gave you is really because it's very ambiguous. No one will say this is what the curriculum is. I mean, we talked about competition or competence by design. You don't have anything as a landmark to say now you are a transition urologist. You have to really jump between adult and pediatric. And this is why we're lucky to have people like Dr. Grimes who are interested in doing this, and Dr. McAkron and Dr. Lynn. But we don't have the fellowship that have been offered, by the way, are not really designated to have a certificate at the end yet, just to let you know.
There are two paths. One is from, as Dr. Brown mentioned, pediatric urology. One is from PERS, right, reconstructive. And to my knowledge, there are only 2 fellowships in the United States that have any kind of curriculum. Lurie's is just opened it, I think, last year. One is with Sean Elliott in Minnesota. The other is with Hadley Wood and what's his name?
And Angermeyer.
Thank you, Angermeyer. And they do recreational urology fellowship focused, again, from the adult perspective on how to manage patients with spina bifida, bladder extrophy, or prior hypothalamus surgery. But like Dr. Farhad said, the curriculum is super. I think Josh brought that Indiana went to Paris actually for 6 months because they have a one.
Well, he did pizza. So there's no path. There's no like I want to do a transition urology fellowship. I think most people who do it in the programs actually get some experience are Minnesota, Utah,
Cleveland
Clinic. Basically,
opening.
yeah, but right. But if you want to like hit the ground, then that's operative, right? You know what I mean? And so in like Minnesota has the Gillette, Utah has an actual clinic. But those are the only places that I'm aware of where you will actually get some kind of volume taking care of those patients. But you also have to check the GERS boxes, right? So you only have a year. So this, that's the problem with that model.
Great. Well, thank you very much, Dr. Sue. Thank you to the pediatric team for the presentations and this is everything that you've done.
President Floppy.